And with no further ado, we are going to introduce Mark Dudzik with his presentation on that. And if you could give a little background about your experience, Mark, I would appreciate that.
Yeah, sure. Thanks. Hello, everybody. It's great to be here. I actually was a founding member of Howard County Our Revolution, and I've kind of dropped back a little bit because of some personal commitments and things like that. But it's it's really exciting to see how this organization has grown, and new people have stepped up to leadership. So that's great. I'm a lifelong union organizer. And in 2009, I helped launch a project called the Labor Campaign for Single Payer Healthcare. And then I worked as its national coordinator until I retired last winter. And I continue to serve as chair of the Labor Campaign for Single Payer Healthcare. So, our central mission in the labor campaign is to move the organized labor movement into the fight for Medicare for all. And we maintain that it's a huge burden for the U.S. labor movement to have to bargain for health care when every other industrialized country in the world, working people receive health care as a matter of right, and don't have to have it tied to their jobs. So that's sort of been our mission. We've worked very closely with National Our Revolution on the launch of Our Revolution, and with the Bernie Sanders both campaigns around the issues of Medicare for all. And Medicare for all, as I'm sure you all know, is a core issue for Our Revolution. So there's been a lot of overlap in our work, and so I was asked tonight, I guess, to sort of just give folks a kind of a state of play where we are on the healthcare stuff from a national perspective. And I'd like to kind of go through that state of play, and then if we have time, take questions and comments on it. So there are currently Medicare for all bills in both the House and the Senate. In the House, the bill is HR 3421. It has 112 co-sponsors, and the principal sponsor is Pramila Jayapal, who also chairs the House Progressive Caucus. 4 of the 8 Maryland representatives are co-sponsors of the bill. That's Glenn, Kawasi, Raskin, and Sarbanes. Harris, of course, is not on it, but also Ruppersberger, Hoyer, and Trone are not co-sponsors of the current legislation in the House. In the Senate, it's Senate Bill 1655. Bernie Sanders is the principal sponsor, and there are 14 co-sponsors, including none of the current senators in Maryland. So that's sort of where the bill is. It's actually, kind of developed into a very substantial presence legislatively. About half of the Democratic caucus in the House now is, pretty solidly in support of Medicare for all legislation. But as Bernie has said, and many others have said, that in the current Congress, single payer legislation is really not in the cards. And that is basically for 2 significant factors. First, how the Republicans, despite their complete dysfunction, continue to control the House, which means under House rules, it is virtually impossible to get even committee hearings, much less floor votes on issues, unless you control the speaker's position and the other leadership positions. And secondly, the Biden administration does not support Medicare for all. They ran on not supporting Medicare for all, and the Biden supporters on the Democratic National Committee defeated resolutions at the the last Democratic convention that would have put the party on record as supporting Medicare for all. So we have work to do, you know, within the Democratic Party and the Biden administration to move it forward. So even though it's not in the cards, it does not mean that we don't desperately need Medicare for all as a solution to this ongoing healthcare crisis. And, you know, I could talk for hours about, you know, what that crisis entails, but I don't think I need to do that. We all know people who, you know, are in danger of losing their insurance, are in massive debt to medical institutions, who can't see the doctors that they want to see and get the treatments that they need, who are cutting their pills in half at the end of the month. We all know those stories of why we need to treat healthcare as a basic right in this country, rather than as a business that's organized to generate profit and sales. So the crisis continues, and really the question that we've all been kind of struggling with is, what can we do in this interim period until we can, you know, come back and put it back on the to-do agenda of the House of Representatives and the presidential to-do agenda. And, you know, I guess the answer, like any other issues, we've got to organize and educate and build, and this is the time to do it. So in Congress, you know, the Progressive Caucus has begun to come together as a more disciplined group of people. There's about 100 members in the Progressive Caucus, and at their last conference, they are now requiring members to co-sponsor at least 80% of legislation that the caucus has designated as key legislation. You know, before that, you could be a member of the Progressive Caucus, say you're a member, and never co-sponsor a single bill that the caucus has endorsed. So Medicare for All has been designated as a key bill for the Progressive Caucus, and, you know, that creates some kind of discipline and an agency within Congress to move it forward. But as I said, you know, there's no chance of having a hearing in Congress through any committee of jurisdiction on Medicare for All, but there are opportunities that groups are exploring to do briefings for congressional staffers and congressional offices on the core issues. These can be really helpful. You know, if you've ever talked to congressional staffers, it's the range of their ignorance on issues can sometimes be amazing, and they really need to be educated on those issues. So there are some opportunities, you know, inside Capitol Hill to do so. Likewise, in the Senate, you know, hearings are possible there. Bernie Sanders, in fact, chairs the primary committee of jurisdiction, the Help Committee in the Senate, and has been very open to the idea of working with Medicare for All advocates on doing hearings on kind of, you know, core pieces of the Medicare for All bill. How are we going to pay for it? Who's going to be covered? What should its components be? And we're hopeful that, you know, once we get through this current period of insanity, you know, we can settle down and do a series of hearings before we move into the next period of election insanity next summer. So there are some opportunities inside the House, and there's some opportunities from the grassroots to pressure representatives and senators to co-sponsor and do more on Medicare for All. And, you know, we would maintain that might include primary challenges where it's appropriate, and where, you know, you have an incumbent who's opposing Medicare for All despite the clear wishes of his or her district. So there's some opportunities there. And then, you know, beyond that, I think where we are at is that we have to sort of defend the current healthcare system and look for opportunities to build the infrastructure that will support an eventual Medicare for All legislation. And that I think there's a lot of work that we can do. First of all, the fiscal 24 budget needs to be passed by mid-November of this year, or else we're going to run out of money again. And all the public health programs are on the table, including Medicare and Medicaid. You know, if these nuts impose their will on the Republican caucus, we may end up with a budget sent to the Senate that massively guts Medicare and Medicaid and other public health programs. So there's going to be a fight about that, and healthcare is intimately part of that. The next area that we really need to look at is this devastating cuts in Medicaid coverage that's been called Medicaid unwinding. There was an expansion of Medicaid coverage during the pandemic that, brought millions of people, gave millions of people access to healthcare, many for the first time. The funding for that expired I think in June, and the states were required to unwind the coverages for those people. But in the process of doing that, they've required people to do all kinds of hoops to certify their current eligibility for Medicaid, and millions of people are being dropped off Medicaid, including many people who should be kept on even under the narrowed criteria. So as many as 6, and nobody's quite figured this out yet, but it looks like at least 6 million people have currently lost access to Medicaid since this unwinding began, and it could be up to 24 million before this thing is over. So this is a huge kind of under the surface catastrophe. There has never been a time in history when so many have lost healthcare in so little time. So, that we need to be responsive to that and try to reverse this unwinding. Secondly, we got to stop the privatization of Medicare. If we don't have a public Medicare system in place when we want to expand it to everybody, we don't even have the structures that we need to build out from there. There's been a couple of major threats to that. The first is a program called ACO REACH, which was started under the Trump administration and continued under the Biden administration, which changes the way that traditional Medicare pays for Medicare and allows for incentives for practices, many of which have now been bought out by venture capital funds and other capitalist enterprises, provides incentives for them to reduce care, save money, and pocket the savings themselves. So a number of groups, particularly led by the Physicians for National Health Program, really aggressively opposed the expansion of this program. And we're fairly successful in limiting it to a pilot program. It was set to expand massively earlier this year. They were able to get the Biden administration to slow down the expansion, but it still exists as a pilot program, and it's a real Trojan horse inside the Medicare system. Second area is a plan that's been around for a long time called Medicare Advantage, which many people confuse with actual Medicare, but it's a private insurance option to Medicare, which is paid for with public monies from Medicare, but is run by private for-profit insurance carriers. And currently now, half of all Medicare recipients receive their Medicare through Medicare Advantage programs. That results in a reduction in services often for the people in the Medicare Advantage programs, and completely undermines the public nature of the Medicare fund. So there needs to be a growing push to stop Medicare Advantage, force the private insurers to play under the same terms that traditional Medicare plays. And there's been a growing awareness of the dangers of Medicare Advantage. We need to capitalize on that and push back on that issue. Other public health programs are also going to be under the gun. We're paying some particular attention to the Veterans Administration, which is, a model of healthcare that's been targeted by groups like the Koch brothers funds to try to privatize it. It'd be a hugely lucrative thing to privatize Veterans Administration healthcare for the medical industrial complex, and they're going after it, even though Medicare, the Veterans Administration, on many measures provides superior healthcare than any other healthcare institution in the US. So we're looking at those type of things. And then the other thing we need to do is, build out this infrastructure. The original Build Back Better bill, which was killed, as you all remember, by Joe Manchin in the early days of the Biden administration, called for expanding existing Medicare by adding dental, vision, and hearing and reproductive health services to actually existing Medicare. That would, make, do to Medicare what we want it to do when we expand it to everybody in the country, have a full range of coverage. So, we were definitely in support of that and would look for opportunities to revise that expansion and also add long-term care to that list. And then, the other thing that we need to look at is the deductibles and copays that are built into the traditional Medicare system that often drive people into looking to Medicare Advantage as an alternative, and force people into buying like a private insurance product to supplement their Medicare coverage. So we need to do that. Another area that people have been talking about is to lower the age of eligibility for Medicare. This would provide relief for people who may need it most, older Americans who maybe retire early or, lose their jobs and can't get rehired, and have no access to health care. It's extremely expensive to purchase healthcare insurance if you're sick and you're 63 years old. So if you lower the age to 60 or 55, you'd be bringing in a huge new group under the auspices of a public program and, beginning to raise the public support for Medicare. Another area would be to look at controlling the power of big pharma. If we can regulate big pharma now, then we don't have to fight that fight when Medicare is on the table again in Congress. So let's do what we can. There's a small opening with the Inflation Reduction Act with negotiating for up to 10 pharmaceutical prices per year. That's under contest right now. The companies are taking them to court, and it's not clear where that's going to go, but it's the first opportunity to begin to do that. There's legislation in the House, HR 4845. Pallone is the principal sponsor. That would open up that negotiating authority to all users of pharmaceuticals, not just Medicare users, and would expand the number of drugs negotiated per year to 50 drugs per year. So that would really, go a long way towards curbing some of the power of big pharma if we can begin to push on this little opening that we have under the Inflation Reduction Act and expand it as rapidly as we can. And then, Senator Sanders has always pushed for the expansion of these primary care health centers that serve particularly underserved urban and rural communities. And he's actually partnered with his Republican counterpart on the Health Committee to call for an expansion of that program to expand the services to include mental health, dental, and nutrition care, and to increase the number of slots open for scholarships for doctors and nurses to serve the primary care functions. So that's a very significant piece of the healthcare system that we could begin to bring under the public banner. And then finally, on action in the House, the whole question of access to reproductive health care has been massively restricted by the Supreme Court Dobbs decision, and most Medicare for All supporters, and certainly the labor campaign and Our Revolution, is looking at ways to restore access to reproductive health care and the right to abortion. There is a bill in the Senate S701 and the House HR 12, which would restore that right to access and restore the right of providers to provide abortion care and other reproductive health care in every state of the union. It has a lot of Democratic support. Both Maryland senators and all 7 Maryland Democratic representatives are co-sponsors of that bill. But, it's a crucial part of healthcare that's been massively restricted. And then finally, I would just like to say, that, the strategy of the labor campaign for single payer, the analysis of the labor campaign for single payer is that the reason that we don't have healthcare in this country is not because we don't know how to do it. Almost every other country in the world has figured out how to do it. So this is not fundamentally a fight over healthcare policy. This is fundamentally a fight over power. And it's the power of the medical industrial complex that's standing in the way of the American people and their healthcare. So what we really need to be thinking about is building the kind of movement that can take on and fight the massed corporate power that's denying people healthcare. And so that's really, what we ought to be thinking about as we move into this, try to move this movement forward during a very difficult time. It's no accident that the movement for Medicare for All peaked during Bernie's 2 campaigns, which centered the fight against corporate power as, the themes of those campaigns. And, if we, continue to build that movement, then, Medicare for All will continue to be one of the key wedge issues of that movement. And, we think, that the labor movement is central to that because the labor movement at its best exists to take on concentrated economic power. So that's why we spend so much time working on that. So I will shut up now and see if we have time for some questions and discussion. Turn it back to Kat, I guess.
Yeah, Paul has a question. He has his hand up.
I hope my internet connection is okay. Is that all right? I get a thumbs up?
We
All
can
right, good. Thank
barely hear you, Paul, so speak slowly, I think.
Yes. Hold on. Mark, think back to 2019, the Biden-Sanders unity task force that preceded the Democratic convention and the subcommittee that Congresswoman Jayapal chaired on that commission. Do you recall some of the items that were on that wish list in the area of prescriptions or expanding Medicare and Medicaid? And the committee, I think the subcommittee was called Achieving Universal Affordable Quality Healthcare, something like that. Does that strike a bell? And do you know if we're getting close to some of those goals? Thank you.
I haven't reviewed those recommendations in a while, so I can't recall all of them off the top of my head. But I will say that I think that the original Build Back Better bill sort of reflected the spirit of those agreements in terms of a fairly ambitious expansion of the services of the existing Medicare, and some of the other healthcare bills have reflected that spirit. The problem has been the blockades, both within the Democratic caucus and particularly the Joe Manchin and Sinema in the Senate, and then the just unwillingness of anybody in the Republican caucus in the House to move on any of these initiatives. So there have been barriers, but I don't know if, Paul, if there's a specific issue from that agreement that you want to feature or ask about. But I think that's there. It did not commit the Biden administration to support Medicare for All legislation, and they haven't. So, and we shouldn't be surprised that they haven't, but my sense is if we can change the facts on the ground, and present legislation to the administration, they may be compelled to have to sign off on it, but they're not going to be the lead on that on that legislation.
We have a question from Jim.
I just wanted to make a comment about the importance of filling some of the gaps of where there are no healthcare providers. So if you look at a state like Alabama or anywhere across the rural South, where infant and maternal mortality rates are much higher than the national average, what you find in Alabama is that 3/4 of the counties in Alabama have no OBGYN providers at all. And a very high percentage of women in Alabama are more than a half hour away by car from any OBGYN facility. So obviously, getting people health insurance is important, but in many parts, and particularly in the rural South, it's really important to add to the facilities that are available. It won't do those people any good to be able to have their services reimbursed when they can't get services in the first place. So the issue that Senator Sanders has been addressing about primary care providers is extremely important across rural America for sure, but certainly particularly in the rural South.
Yeah, I think, Sanders is really brilliant on moving on that issue. First of all, his state is a very rural state, needs those kind of centers. And it creates a bridge with some, not all, but some Republicans, and because it is a service that they realize, these rural hospitals are closing and the services are diminishing. So it's an important initiative. And, it also applies to urban areas that have limited access to healthcare, and so it creates some bridges. So I think it's something that has some ability to move forward and could make a real difference in a lot of people's lives.
Are there any other questions? If there aren't, you can unmute yourself.
I think Alan's got his hand up.
Alan, go ahead.
Yes, in Maryland last year, the Medicaid for children under 20 for diagnosis and some treatment was expanded. And there's maybe an effort this year to expand that same to older Americans. So it has to do something with diagnosis, some additional treatments. Are you aware of that?
Yeah, I don't follow the Maryland healthcare stuff in great detail, so I'm not aware of the specific legislation, but I think there's been a lot of talk about moving like the CHIPS, the Children's Healthcare Program nationally, into sort of a universal program for children. It actually doesn't cost all that much money to provide guaranteed healthcare for children. They don't use a lot of health. They're not like older people like me, who are always going to the doctor. So you could conceivably provide universal health care to everybody under 21 in the country for much less than you could do it for everybody over 55. And so there's some talk about thinking about those type of opportunities, and it's just, again, it's an area that's people could really benefit from and desperately need. So there might be some movements there. Some states have tried to do that. I think Vermont is trying to make primary care available universally for all children, but certainly something that people are looking at and experimenting with.
There's another subject with regard to climate change. One way to move forward a little bit is to have unlimited, endless penalties and no time periods or no lapses for those that damage the environment. Is there anything happening on the federal level that would increase the responsibility of those who cause damage for all of the consequences?
I'm not aware of anything. It's a good idea, but I'm not aware of anybody working on that.
A little bit like the Montana court decision, where the children won a victory that they are entitled to a better future. That climate change needs to be considered.
Yeah. It's an interesting area to explore, but I don't know if anybody's doing that at this point.
Thank you.
And it looks like Paul's got another question.
I'll try. Mark, in Canada, didn't they, nothing.
Can you type it in, Paul?
Maybe, yeah, type it in the chat.
You're just really distorted now.
Well, at least Paul knows how to get a hold of you if he needs to ask a question.
Yeah, maybe I'll change my phone number while he's away, but
Says, oh, in Canada, didn't start by province and with hospitalization first.
yes, it did. And there's debate, and the Labor campaign supports efforts, viable efforts, like we like to say, to enact state level legislation to try to create universal health care. It's harder to think about how you're going to do it on a state level. There's a lot more barriers, which I could get into that if people had a bunch of questions on it, but there are a lot more barriers, not least of which is how you can provide a steady financial support for it. But it may be that a state like California, is the first, has a breakthrough, and that it sets a standard for the nation. So it's possible that a state by state approach will do it. Ultimately, we need a national healthcare system. You can't, fragmented systems, even on a state by state basis, won't provide the comprehensiveness and the financing and the stability that a national system would. But nobody has a magic map as to how we're going to achieve this. So we support anything that seems to make sense in terms of having the capacity to move the battle forward.
All right, so I guess if there's no more questions, we're gonna wrap up a little bit. I did want to announce one thing before I left, and we still have a few people left on. I am planning to step down as co-chair of our Rev the end of October, and hopefully we'll get someone to go into that position to help Jake out. I am going to be running for Columbia Association Board for Wild Lake. For those of you who might live in that district, I'll need all the help I can get. And hopefully I can talk to Jim more off the OR meeting, because Jim has a lot of good information. And with that, Jake, do you have anything else to add about?
Yeah, I do about you, stepping away, and sad news, but wish you luck in the Wild Lake CA board, and we definitely need more grassroots people. But before I say anything, I see Kim has her hand up, so.
Oh, sorry, I didn't want to interrupt. I have a question about labor relating to local unionizing efforts in hospitals. And I just wanted to know if anyone was aware of anyone trying to unionize at Shepherd Pratt locations. I'm currently a part-time employee there, but I'm also a manager, and I got invited to an anti-union. They basically had an executive meeting where they hired an anti-union lawyer to give a presentation of how to block unions from forming legally. And I wanted to see, because I don't really have, I'm isolated where I work. So I wanted to see if I could find out anyone who's organizing there at any of their locations across Maryland, to get them the information that I found during that presentation. And I'm also really curious about what happened with any unionizing efforts at Hopkins. Because I was given to understand that they failed, or a vote, or that they were trying, but there was a failure there. because I know St. Agnes is now in GBMC. I'm a nurse, full disclosure. So I know that there's a lot of motivation for nurses right now and hospital staff.
Yeah, can I just say a couple things? I mean, I don't know about Shepherd Pratt, but I've been a union organizer for a long time, and I would imagine that since they've just paid for a anti-union attorney and consultant to begin to do this work with management people, that something's going on. So, should keep your ears open and out. And, on a personal level, I would say if you're considered a manager, also keep your head down. You're not protected
Absolutely.
the Labor Relations Act. So, just be aware of that. But, look for an opportunity to do that. The Johns Hopkins, their main hospitals, the service employees are represented by 1199. The nurses had a unionization campaign there a couple of years ago that kind of stalled. They just couldn't reach sort of the super majorities that they felt they needed to withstand this anti-union campaign once they filed. So they've kind of put it on hold. I think that there's still a presence there, but there's not as they're not actively trying to move to a union election at Hopkins.
Thank you.
Well, yeah, and thank you, Kim, for the question. I didn't know that there may be. Yeah, I mean, I guess your assumption, Kim, is probably that if Shepherd Pratt is doing these anti-union sort of meetings, maybe they caught wind that there are sort of efforts going on, and so that would be exciting if that is true. Maybe they're just being proactive. Who knows? Maybe time will tell. But
They're bleeding staff so much. I don't know who they'd organize at this point.
okay,
So
I see.
it's rough.
So, yeah, probably as a result of not great conditions. Maybe that's why they're leaving staff. So yeah, not too uncommon in the health care world, it seems like, unfortunately. And so thank you for putting that on the radar, and I guess we'll keep an eye on that there. And thank you, Mark, for the presentation, for answering the the questions.